Good afternoon. My name is Grant Miller, and I really want to thank you for joining us for our keynote event for the Rosenkranz Global Health Symposium here today. Before I tell you any of what I'm supposed to tell you, which I have all written down here, I want to first thank, first and foremost, our spectacular staff for making today possible. Really and truly, this wouldn't happen without them. They're amazing, and we're incredibly grateful. So otherwise, we are here thanks to the great generosity of Dr. George Rosenkranz and his family, and to continue his legacy by awarding first the Rosenkranz Prize to Stanford scholars who are doing innovative and impactful work to improve health in middle and low-income countries. So I'm just going to tell you very briefly about Dr. Rosenkranz, given the importance of this event being named after him. So Dr. Rosenkranz devoted his career to improving health around the world. He was born in Hungary in 1916. He trained in chemistry with Nobel Prize winner Leopold Ružička. He helped to first synthesize cortisone in 1951. This remarkable discovery made in Mexico by Dr. Rosenkranz and a team of other young scientists was critical in shaping his career focus. Later that decade, Dr. Rosenkranz's team synthesized the active ingredient for the first oral contraceptive. Then afterwards, partnering with a Wall Street investor, Dr. Rosenkranz went on to become the CEO of Syntex Pharmaceutical Company, which was a position he held until 1981. Outside of that, he really committed his career to reducing health disparities around the world, and this prize that I'm going to now present in one moment honors his legacy. So I'm very grateful that Dr. Suchi Anand, who is here, and Dr. Iran bin David joined me this year in our prize selection committee. And this was an extremely competitive application cycle, and because we were not able to award the prize during the COVID pandemic, we're excited to announce two prize winners this year. So our first winner is Dr. Jade Benjamin Chung, who is an assistant professor of epidemiology and population health. Dr. Benjamin Chung, no, please don't applause yet. Dr. Benjamin Chung's proposed work starts from what you might call the disappointing results of two very high-profile randomized controlled trials of water sanitation and hygiene interventions, sometimes called WASH by insiders. So WASH programs have historically been central strategies to combat childhood diarrhea and other illnesses, but these two gold standard WASH benefit studies found only modest benefits in reducing childhood diarrhea. So this led to a large rethinking approaches to diarrhea prevention. The premise of Dr. Benjamin Chung's work is that soil floors in many homes, particularly among many of the poorest around the world, are commonly contaminated by E. coli and intestinal helminths, and children frequently ingest household soil. So her proposed work will study the benefits of home floor improvements, in particular with concrete. There's already suggestive evidence from observational studies that this approach may be highly effective in reducing key childhood illnesses, but her work will rigorously estimate this effect through a randomized controlled trial and examine many broad dimensions of childhood development that may evolve on a more hopeful path as a result. It's surely not feasible to install concrete floors at large scale, but rigorously demonstrating the importance of this pathway could really lay the foundation, I guess pun intended, for the development of cost-effective and feasible larger scale interventions targeting contaminated household soil floors. So Dr. Benjamin Chung, please come to the stage. So our second winner of the Rosenkranz Prize this year is Dr. Arthur Brandt, who is an ophthalmology resident, and he enabled to escape clinic to join us here today. He's here at Stanford. Dr. Brandt studied computer science here at Stanford before joining Google Life Sciences as a software engineer. While he was there, he founded and launched the Cloud Healthcare Security Team, and he published research using smartphone features for clinical applications for detecting a variety of illnesses, including clinical depression. He continued his work full-time at Google while also attending medical school here at Stanford. I didn't know that was possible, but I'm now reconsidering my choice not to pursue medical school myself. While doing this and while working in Ghana, he became interested in sickle cell retinopathy and began a long-term collaboration with Dr. Akwasi Ahmed, who is the only retinal surgeon in Kumasi. The two of them designed and tested a novel, low-cost imaging protocol for identifying sickle cell retinopathy using photographs taken by nurses. So I think you can see the potential of this. With support as a Rosenkranz Prize winner, Dr. Brandt plans to expand this collaborative work by launching 3 additional screening sites, including one focused on children at schools, and to launch the first randomized controlled trial in over 30 years to investigate the efficacy of retinal photocoagulation for sickle cell retinopathy, all with the ultimate goal of creating the first screening and treatment program for sickle cell retinopathy and preventable blindness in West Africa, and to do this at low cost. So Dr. Brandt, please come and join me on stage. That's upside down. Okay, so I'd now like to introduce Dr. Aren Ben David and welcome him to the stage to introduce our guests for our keynote event.
Thank you, Professor Miller, and heartfelt congratulations, Dr. Benjamin Chung and Dr. Brandt. And I would like to second Dr. Miller's expression of gratitude to everyone here in the audience, to our day's speakers, and really especially to our wonderful staff, especially Suman, Misty, Beth, and Dan for making everything we do look easy. I'll give you a hint, it's not. Okay, we have an exciting hour ahead, and it is my distinct pleasure to introduce our keynote speaker and her host. I am beyond thrilled that we have Professor Sheila Tlou with us today. I first learned of Professor Tlou, when around 2004, I gasped to learn that the prevalence of HIV among pregnant women in Botswana was touching 50%. 50%. And at the same breath, I learned about Botswana's commitment to turning that around, commitment to putting as many people as possible on antiretroviral medicines, and to putting public resources and public attention on health. Professor Tlou was the Minister of Health in Botswana at the time and spearheaded and really orchestrated that turnaround. By the time she left her position in 2008, the HIV prevalence among pregnant women was under 10%, and today it is under 1%. That is a remarkable achievement. Professor Tlou trained as a nurse. She holds a PhD in nursing sciences and another degree in women's health and gender studies. She has been a champion for HIV care, for women's health and global health more broadly, and I'm sure we'll hear more about that today. Following Professor Tlou's talk, she will be joined on stage by Michele Barry. Professor Barry needs no introduction in this forum. She's the Drs. Ben and H.S. Chanson Professor of Medicine and Tropical Diseases. She's also the director of the Center for Innovation in Global Health here at Stanford and a senior associate dean for global health. Professor Barry's indefatigable interests and passions have propelled her to leadership positions in global health, health disparities, planetary health, and women's health. The list is long. Particularly notable is her recent founding of the Gates-funded Women Lift Health, which works to train and place women in top leadership positions in both public health and private sector health organizations. Dr. Barry will facilitate the conversation with Professor Tlou and will moderate audience Q&A following Professor Tlou's talk. We will have a microphone available at the time, so hold your questions, and those will come. So without further ado, please help me welcome Professor Tlou to the podium.
Thank you very much, Aaron. Well, let me say good afternoon to all of you. And I want to just say how well educated I was this morning. I participated in the sessions all the way from 8:30 up to the last one. And I want to thank you for getting rid of my jet lag. Yeah, so it was great. But I want to also start by thanking Dr. Michele Barry and the staff for inviting me here. Actually, this invitation was long overdue. I should have come here, when, 2 years ago? And then there was COVID. But now there's no COVID. So I'm here, and it is great to be here. And I really want to thank the staff for organizing this, and to thank all of you for participating and attending this. I've been asked to condense work of 40 years within 30 minutes. So I'll try to do my best, but the rest you'll have to read. Either you Google me or you ask questions and we shall talk. But it's a long story. So with that, let me simply say what I learned in the morning, I'm now sharing with you on looking at global health equity, and really looking at the value of evidence-informed decision-making. And basically, I mean, if I forget to tell you, in case I don't say it anywhere else, it's really to just say, look, research is where it's all at. If we are going to have global health equity, especially in implementing the Sustainable Development Goals, we need to do research, preferably collaborative research, multidisciplinary, for decision-making, and hoping that with that, we will then have a better world, a world that is prepared for future pandemics. Because my belief is that, yes, we will have future pandemics, but I'm hoping that we will be better prepared than we were with the COVID-19 pandemic. So there I am. I'm not going to say, I already have those, a few formats that shows you just how old I am. Quite a few formats, but now one of the things that I'm doing is being the ambassador for African Leaders Malaria Alliance. They accused me of having done quite a lot for HIV and TB, but leaving out malaria. So I was appointed ambassador for malaria to say the same mosquito noise that you made into our ears regarding HIV, make it regarding malaria. So from here, I'll be going to the World Health Assembly in Geneva, and most of the sessions that I'll be participating in are the malaria ones. So wish me luck, and let's hope we will also eliminate malaria, because it now has its own complications. Yeah. So with that, I'm sharing what I'm going to be doing. Is just to really look at my own personal experiences in improving global health through research, education, advocacy, and policy change. And I want to emphasize the advocacy part, because half the time we do research, but then if it's not going to end anywhere, it's going to be on the shelves, then it really doesn't lead to a lot. Or if it's going to be published in internationally reviewed journals alone, and it's not therefore translated also to be consumed by the decision makers, it's exactly that, research. So I'm hoping that what I heard this morning will actually be translated. It was great to be getting all those graphs with correlations and all that. But listen, to a politician, there's nothing like that. They want something that's written in 2 pages. And if you can't say it, then forget it. Say it in 2 pages, what you saw, what you think should be done, and how much it will cost. Amen. So it's basically that. So, but we talked today, what we are all talking about relates to a lot of this. A lot was covered. I like the gender part because I know Dean Michele Barry is now numero uno when it comes to that, women lift health. So it's really that, but those are the social determinants of health that we need to be able to do research in. We have those epidemics. We have the global inequity. I was talking about the future pandemics because I'm hoping that what happened, the vaccine hoarding that was done by the West, never gets to be done again if we are going to achieve global health equity and collaboration. We got to a point where the Western countries were hoarding the vaccines, and we, at one point when over here they had, vaccinated 80% of the people, Africa was still at 3%. And we were there, looking at what needs to be done, but only small countries like Botswana were able to vaccinate, because I come from a country the size of Texas, but with only 3 million people and well-resourced, so we are able to actually vaccinate 70% of the people within a short time. But that didn't happen with other countries, so that we could have had really untold effects, and we could have had even more people dying in Africa. But I always say to people, God's hand was there, because between the Western world that didn't care and our own leaders who had no clue, we could have died. But somebody else more powerful was right there. So I want to also focus on the last one, the human resources for health shortages, because I know that's probably going to come up. The fact that that the global health inequity is actually being shown right now, where we are having a brain drain from the developing countries to the developed countries. So it really means we need to sit down and say, how do we address this in such a way that no one country is left, to just to be affected so much that they can't do anything. So we'll talk about that. But I'm going to leave it at that and simply say, when all this was said and done, my own religion in all this, because they've always been there, was primary health care. This is as relevant now as it was 45 years ago. This was a global declaration, health for all by the year 2000. And it just so happened that for us in Botswana, it came at a time when we had just got our independence and had discovered diamonds, so that already healthcare was free. Already education was free, because we had very few human resources. Therefore, we needed to just make sure that education is free. It still is free now. But I like this, and I still like it now, because it's talking about accessibility. It's talking about affordability and really community engagement. Because in the ultimate, what was happening today, I listened to some of the research projects, and the community aspects seem to be lacking. Where you say, well, how do you engage the community in this? Could it have been the community, instead of you making a decision to do this? If we had engaged even the chiefs, what would have been the outcome? So I like that, and it caters for a lot of neglected groups, older adults, even key populations. People have always said, oh, key populations, and I said to them, look, key populations are mentioned even in primary health care. So we are right there. But it was a great success in my own country, and I got interested in it from the human rights and gender perspective. That was saying, okay, well, we are saying, let's talk about maternal and neonatal health. But what about the woman who cannot bear a child, or who chooses not to bear a child? What about the woman who is an adolescent, who still has to be taught on menstrual hygiene and all that? And what about the postmenopausal woman? Is she not worth it? So that was from that, I became an advocate from that viewpoint, because I really believe that we need to take care of women also in their diversity, from the womb all the way to the tomb. So that was basically that. So, but what did I learn from primary health care? That health, yes, is made in the home. Health is made in the community. Hospitals are for repairs. And I had a country that when we got our independence, and during the time even when I was minister, we had very few medical doctors. In fact, I participated myself in the medical program for doctors, and the School of Medicine was opened when I was a minister. So we relied a lot on nurses, on midwives, on family nurse practitioners, and on people that are sometimes not even talked about, community healthcare workers. They were the ones who mobilized women for healthcare and ensured that we had safe deliveries and all that, at least until HIV came, when now it meant, a different form of healthcare. So there we are, and what I did then was to say, okay, how do I document that communities do matter? I documented the impact of HIV on women, And as an educator and WHO Collaborating Center coordinator, this was coordinator for Anglophone Africa. But because even Francophone Africa had no WHO Collaborating Center, we had to put in nurses that were training in the AIDS response. And I was really happy because when now the AIDS epidemic was at its peak, these very nurses were now the directors in Ministry of Health, being HIV/AIDS coordinators. So that there we had now people in leadership positions who could do a lot in the ministries, not just the Ministry of Health, whether it was agriculture or education or whatever, there would be an AIDS coordinator, and that person was a nurse prepared at master's degree level. So it was great. So I also documented, the community participation and ensured that the women themselves took a lead in their own care. So in 1988, we formed, with my colleagues, we formed the Society for Women and AIDS in Africa and ensured that they are there in every country to do advocacy, to ensure that whatever new treatments, remember at that time there were no treatments, whatever new treatments came up, to ensure that they also have access. But not only that, we had to also face that reality that these people could actually, or these women could actually, will eventually die since there was nothing. And therefore we worked with lawyers to help them make living wills so that at least it takes care of for their families when they are gone. So that's me with some of the graduates of the nursing program. And quite a few of them, yes, became the AIDS coordinators. And some of them are now permanent secretaries and all that. So, and one of them in there is actually a minister of health. I'm glad that I was the first person to be appointed a minister of health in Botswana, the first health professional. We'll talk about that anyway. But what else have I learned? My role as a political leader simply meant that, okay, what did I need to do? Let me say, as Iran presented, Botswana was very much affected by the AIDS epidemic. And at that time, I happened to be a professor at the university doing my research, but also an activist who was saying the government shouldn't do this, the government is not doing this, that kind of thing. So that, yes, in 2004, President Mogae, who was very much an AIDS activist, appointed me Minister of Health. I would like to think that it was because of my activism and my expertise, rather than let's shut her down, shut her up. But that was also, I think, because when you make it out of noise, somebody should be able to say, come over and show us what it is that we think we should be doing. And I did. But I took that as a honeymoon phase because they had said, as African leaders, that they were going to devote 15% of the budget to health. And none of the African countries had done so. Botswana at that time was about 12%. So I simply said to him, I'll be a minister of health only if you give me 15% of the budget. But guess what? I got 22%. With real expectations, he said, I want a report every 3 months and it better be a good report. But because of my work, as an activist, as working with communities and NGOs, I was able to bring people together and say, guys, we have money. Let's perform miracles. And we engaged everybody, the traditional, leadership, nurses. We had we put up an integrated patient management system that enabled you to take your ARVs in San Francisco. But if you happen to later be in Los Angeles, we simply went onto the laptop and we saw what medications were in and were able to get that. So we didn't care where you are, but you got your medications. So that was really that. We put up a comprehensive prevention, treatment, and care supports program. That is still a model because when I was now regional director, I was able to actually talk to the other ministers who'd say, yeah, but we don't have resources, we don't have health human resources. I say, if you have nurses and you have nurse practitioners and you have midwives, you can do. It's a resource-limited setting, but we can get the great results. And indeed, we saw mother-to-child transmission go down from 29% to 8% within 4 years, and now it is less than 1%, because later when I became regional director, I was now sitting on the Minister of Health in Botswana saying, don't mess up my statistics. Let's go down. And it is now less than 1%. But it meant also collaboration to influence policy reforms, because the best way to prevent mother-to-child transmission of HIV is to prevent the women from being infected in the first place. So that it meant putting policies on gender reform, advocating for a lot of things. For example, I'm talking about this abolition of marital power. I won't go into it, but actually it gave women, therefore, that independence over their property, their bodies and all that. But before, it was a law that we had inherited from Britain, and it gave power only to the husband. So you can imagine the poverty that some women got to be exposed to, but we got rid of that. And indeed now, everybody is right there, is equal. And okay, the last thing that I've learned, one thing that I've learned from primary health care is that health is a political choice. It is a political choice, but it is up to you, therefore, as researchers, to be able to present your evidence in such a way that it can influence change. So, like I said before, we need research for gender equality, for human rights, for equitable access to services, especially men. When I talk gender most of the time, even when I was a minister, I made sure that I focused on men, because in an African setting, being sick is not masculine. And therefore, you would have women come to test, get access to medications, but the men would stay behind. So I got to have voluntary counseling and testing centers actually focusing mainly on men, and that improved their access to services. So key population groups, we were able to do that. But I'll tell you, this may sound like it was great, it was easy. It's not easy to advocate for sensitive topics. I'll give you an example. Condoms in prison. When I was a professor, I could take students over, and we saw that, we had research done that showed that people were uninfected when they went in, but infected when they came out of prison. And therefore, we used that to talk to the warders, and they agreed that, this is against the law, but you can bring condoms in. Suddenly, I become a minister, and I'm thinking, now I have the power. I'm going to take condoms to prison. Hey, when I presented that memorandum to cabinet, my fellow ministers, they nearly killed me. It was like, you are going to be bringing hell and damnation to this country. Don't even think of it. And I had talked before, I had pre-talked with the president, and he had supported it, and he says, no, I think your colleagues will really understand it. No, they didn't. They shot it down. And in the ultimate, what my poor president could say to me was, well, as minister, we go according to consensus, so maybe you should continue just, smuggling condoms into prison. And I'm thinking, really? But it ended there. It's only much later that we were able to do that, but when I was now regional director at UNAIDS. So, but it was really that, and half the time, I'll be saying to my colleagues, guys, I am a scientific reference. I'm not a moral reference. I am a public health person. I have to say what the research, is saying. I have to see what the research is saying. So I've put this guy here. This is Kim Muswati of Eswatini. He is the one person who really I was able to work with as a minister, but also later as a regional director. And I know he's done quite a lot of work for his own country, Eswatini, in terms of bringing down even mother-to-child transmission, but also keeping girls in school. He has been very good at that. I know he sometimes he's been noted for other things like polygamy, but actually he has done quite a lot. And this is Dr. Gengob of Namibia. We had to engage ministers, heads of state also in sports, somebody was saying they're going to do sports medicine. Okay, I had to engage them in HIV prevention in sports. And here he was signing a ball, in protecting the ball and making sure that football and other players actually are free from HIV. So basically, that was that. But the last thing that I learned from primary healthcare is that global health equity is for the future of humanity. We are, in the ultimate, branches of the same trees and leaves of the same branches. What affects one country will affect the other. And indeed, no country is safe until every country is safe. So we need that research for pandemic preparedness so that, it should be global and it should not be concentrated. So we need collaboration and research advocacy so that everyone, everywhere has access to good health care. And we need, indeed, community ownership. Half the time we want to do the scientific studies, but they should also be qualitative and involve the lived experiences of those at community level, especially women. So my activism for universal health coverage, I'm just mentioning this one because I want to finish. I'm mentioning this one only because I'm using, as you can see, the nursing now. And my thing has been that, look, in resource-limited settings, nurses need to be retained, they need to be educated, and they need to be in leadership positions. That's the only way we are going to achieve universal health coverage. Otherwise, if we are going to rely on other, doctors, a lot of countries don't have that, and when they train doctors, they leave. So maybe we need, therefore, people who can be at grassroots level, but even those ones leave. So we have to find a way of collaborating in the education of nurses and really utilizing what we have, especially faculty, to say how do we collaborate globally in the education of nurses, in the education of family welfare educators or primary healthcare workers. So we need open and constant, collaboration, involvement. So it's basically that was the main advocacy. But indeed, it's simply saying that for us, we need activism, we need research, and in my conclusion, I want to say leadership for research in global health equity. It firstly requires that research. We have already said so. So we need data. I'm glad we were able to see how data is produced today, but that data has been condensed in such a way that it can be consumed by any one decision maker. And as I said, for a politician, make it 2 or 3 pages. The rest of it, they won't read it. Make it and cost it, because then they're able to say, how are we putting money into this? So let's have collaboration between local and international stakeholders in research and advocacy. And we need to strengthen community systems if we are going to really achieve global health equity, because every country has communities. And as I said, healthcare is made in the community. Hospitals are for repairs. Another thing that I like, the fact that for research to really be great, the very thing that happened today, we need the solid researchers, the seasoned ones, to be able to mentor present and also future researchers. So I'm glad of what was happening today, where we're seeing people representing the research, but also having questions and suggestions as to how else they can be able to look at the problem. So it's to really say, kudos to you. Let's keep it up, and let's inspire future generations to do research. And the last thing that I always like putting is to say, researchers, we are doing a great job. But guess what? We really need to be also in places where decisions are made. Can you imagine if all of you right now were ministers of something? Wouldn't we have a better world? But no, half the time we vote in people who have no idea of what people need. And we think they would do a better job. Really, no. So I normally just say to, especially to women, to say, look, remember the story of Adam and Eve. When God asked Adam what they had done, he said, he could have given a very nice excuse, but he said, the woman that you gave me made me do it. Men never spoke for us then, they never will. So, so women, if we want to go to have where gender decisions are made, we better get in there and be politicians ourselves. And if there's anybody that wants to be encouraged right now in terms of politics, I'll tell you, it is really grand. Get in there, because I believe that when she leads, a lot of things happen. So with that, thank you very much. Yeah.
So welcome, and thank you for that wonderful talk.
Thank you very much.
I really resonated with one of your statements, and I'll say it: health is made in the house, but hospitals are for repairs.
Yes.
I really resonated with that. We're sitting in a country that has no community healthcare workers to do things in the house. We're sitting in this great university that actually, I don't know if you know, does not have a nursing school.
Okay.
We do not have nurse practitioners that are as active as they are in the developing world, or
Yes.
LMICs. What are your thoughts about how to empower community healthcare workers, nurses, women to actually become advocates for health?
Well, in your case, since there is no nursing school, it simply means those who are doing research to collaborate with where there are nursing schools. I'm sure there are community nursing schools where this can be taught research, and to focus more on community, what communities want, what communities are saying, what leaders at community level are saying. And we can be able to do that, yes.
And how do you empower women where you are in Botswana to become community advocates in healthcare?
Well, actually in Botswana, we are loud mouths. So we are always community advocates. I have a colleague from Zimbabwe. She'll tell you that women from Botswana are something else. We are few, and we know each other, and we are very well educated. The literacy rate for Botswana women is far more than that of Botswana men. So we've always been that empowered to know what we want. So it's really a question of making sure that they are aware of what needs to be done, what are the health implications of what is happening now, and to say, how do we take it up? And the good part about Botswana is that I was trying to actually make Africa do that, is to really say we vote for people according to what they stand for. You know? So you are able to say, tell us what you are going to do regarding mother-to-child transmission. And any one councillor should be able to be articulate on that. If they are not, then they are not voted in. So that riff-raff and rubbish we don't take. But it's great to actually, because a lot of people say awareness raising, fine. But where women are already educated and they are actually that articulate, is really to harness that power, to be able to say, where do we take it now from here?
It's actually been shown that putting women in power actually has better health outcomes.
Yeah.
But I have another question for you that you said research is power. And you've heard wonderful presentations today.
Yes.
Unfortunately, I was elsewhere, but I heard they were fabulous.
Yes.
How do you develop equitable research collaborations between LMIC and HIC countries?
We need funding. And the one thing that I didn't talk about what was happening in Botswana, and that I'm trying to even get most of Africa to do, is the funding in research. Research is not well funded in low middle income countries, in middle income countries. So that we need that advocacy to be able to say, look, people, if we are going to have evidence-informed decisions, get where people can be able to do research. It may not even be just academic research. It may be even the ordinary medical doctor who is in a ward, who is noticing something about that ward and can be able to say, let me get to the bottom of it. So it's basically that we need to inculcate into our leaders, really the importance of research. Yeah.
And equity in research, where we're working right now, our NIH, when we get a grant, we get like 53% extra, and when it goes to an LMIC, it's 8%.
Yes.
So there's really inequitable sharing of resources.
It's inequitable, but at the same time, we need our own leaders to also be aware. I mean, you know, this is a catch-22 situation. Even for the COVID, you know, pandemic, you know, much as I talked about how the vaccine holding and all that, I had to talk to our own presidents to say, what are you doing in terms of research and making sure that you have your own vaccines in your own continent? So it's only now that we have centers that are going to be doing vaccine. But we need to be able to say, look, if we have collaboration with the upper income countries, let's also put that effort to be able to meet them halfway. Half the time people just sit and think, no, they'll get money from NIH, and we're thinking, where is the data going to come from? It has to come from here, and therefore we need to also put in money. Yeah, if we're going to own the data. Otherwise, don't be too surprised that you get your data and it goes to America, and then you start complaining. Because who funded it? Americans. Yeah.
I'm with you. I'm with you.
And that's what I tell to our heads of state, and of course they go, yeah, you are right. But then are they doing something about it? I don't know. So anyway.
So I'd like to move on to HIV, because you're such a force in the HIV world.
Yes.
And HIV is really, you know, with COVID-19 and hemorrhagic fevers, it's sort of taken a backstory to health. And right now, I looked up the numbers. There are 40 million people around the world that have HIV, but 2/3 of them are in Africa, still suffering. So what do you see as the biggest obstacles for bringing that issue up to the front again? Or should it not be?
The biggest obstacle is that those people are alive and are actually okay, thanks to ARVs. So you're finding that really we now want to focus more on prevention. That's why I'm chairing the Global HIV Prevention Coalition, because we are saying people who have been living with HIV, who had access to ARVs and who are now working and all that, they seem to be living forever. Actually, it is very interesting. With my having worked with people living with HIV for now 40 years, a lot of those women are alive and they are fine. But those who are not infected with HIV, they are dying like ordinary people. So that you are wondering, I guess maybe it's because the ones living with HIV are taking care of themselves more. If anything is happening, they go to the clinic. Whereas the other ones just figure, we are okay. You know, if anything is happening, it's like, oh, maybe it's due to old age. And, you know, the person, gets to be, disabled and all that. So it's really to say, we need to still focus on HIV because it's not over. But more important, because the funding for HIV has gone down, we need to take AIDS out of isolation and really ensure that when we deal with health, we are putting together all those diseases. As in SDG 3.3, it is saying get rid of the epidemics of HIV, TB, malaria, NCDs, and neglected tropical diseases, which to the heads of state, I told to them, there is nothing like a neglected tropical disease. These are diseases of neglected people. You know, no head of state ever mentions chikungunya, Lassa fever, or why? Because it happens to the lowest people. So it's high time that we put them together and said, with the funding that we have, let's get rid and ensure a healthy climate, a healthy planet. That's all. Yeah.
So I'd like to follow up a little bit on that, because prevention is clearly where you're going and where your passion is now.
Yes.
So when you have a society that's very homophobic, say, let's just give you an example of Uganda, where there's a death sentence essentially for folks that are basically gay. How do you bring that prevention to this marginalized population? Right
now, it is a problem because it's interesting, like I said, there are topics that are sensitive. So it's interesting how I'd go to Uganda, be able to talk to the president on mother-to-child transmission, and we'll go to the regions such as Karamoja, the remotest area, and we can do quite a lot on that. Like right now, I'm preparing, I'll be going to the first lady, to her first lady, the first lady of Burkina Faso, and we'll be talking mother-to-child transmission, we're fine. But immediately, you mention men who have sex with men, sex workers, it's almost like, no. I don't know, I mean, the head literally goes under the sand. But what I did when I was regional director was to do a mapping study of just to say where are they in every country. So I would be able to go over and say, Your Excellency, you have the key populations. You don't have drug users, but you have men who have sex with men, whose infection rate is 30%. You have sex workers, infection rate 20%. So how do you and I work? I don't even say, what are you doing? I say, how do you and I work to ensure that they have access to services?
It goes back to evidence as power.
It goes to evidence as power, because if you don't have that, they'll say to you, we don't have them. But if you come in with evidence that you say, no, here you are, it hits you in the face and you cannot avoid it. But some don't like it. I had a president say, Professor, God did not create Adam and Steve. He created Adam and Eve. And I said, yes, Your Excellency, but Steve is here. And he is your child, yours and mine. As an African mother, with children in that diversity, all I'm saying is Steve should have the same privileges and rights as Adam and Eve. Is that a lot to ask? The silence between us was only a minute, but it looked like it was like 3 hours. When he finally spoke, he said, yeah, no, I guess when it comes from an African mother, I have no choice, but you shouldn't let the West shove this down our throats. I went, Your Excellency, are you aware that if you and I did what needs to be done to for our children, the Western world would not be shoving anything down our throats? Another 3 hours of silence. When he did, he said, no, you are right. Okay, no, we'll make sure that we have programs for them. That's all. Yeah. And, when they did have programs, I went back and I said, Your Excellency, when you started programs for men who have sex with men, did your country burn? No, it didn't. Okay, thank you, Your Excellency. So let's continue. So it's basically that. Yeah, there are some topics that we have to tackle with, they're delicate,
delicacy.
but they have to be dealt with. Yes.
So another question around this, what is your perception of U.S. PEPFAR? Can you tell me the good, the bad, and the ugly?
U.S. PEPFAR is actually good. It was a little bit bad during my time. I was the potential first recipient of the PEPFAR program, 2004. And you know how, donors like to jump on the bandwagon of success. So right away, I knew with the success that I'm having, they're going to come. So that what then happened was they had their own terms. I don't know if people remember, the first PEPFAR program, you could not give condoms. You had to speak only abstinence and being faithful. And I had the money, with 22% of I had money to be able to do. So I simply said to them, no, I'm fine. The money that you give me for abstinence and being faithful, I'm going to collaborate with the Ministry of Education so that we teach our children life skills education and all that. But I have my own money, I'll use it to get condoms. And they were going, yeah, but we don't know if Congress will like that. I said, no, your Congress cannot come and dictate what's happening in my country. So if that's the case, then you can take the money and vamoose. And they didn't, because it was good. It was good to be here. So we had a good relationship then. Yeah, but I felt bad for the countries where they didn't have such funds and therefore had to be dictated on terms that were just not realistic. If you are saying you're not going to give condoms, what do you want people to do? You're forcing everybody to to abstain, really. So that was the thing. But now the current one is fine. It's just that sometimes people have complained that their costs, their prices are a whole lot more than, the local prices. Like, for example, some would say, for a circumcision, for example, we are paying, if it was our own program, it's like $5 per person, whereas if you put PEPFAR in, then it becomes 30. But then, it's a give and take. Yes.
It's interesting now, the new head of our PEPFAR
Yes.
is, that used to be the head of CDC Africa.
Yes,
So
yes.
it'll be interesting to see where that goes.
Where it goes, yes.
He's an interesting person.
Yeah.
He's nice.
Yeah. But otherwise, it was a good program, and I'm glad that it happened, and President George Bush was able to see the end of it, in the sense that later he came over when I was regional director to say to me, we are now starting the pink ribbon, red ribbon, so let's go and launch it in Zambia. And I went with him to launch it, so that it was actually accepting that relationship that we had, that showcased PEPFAR as being a success in working with African countries to stem down the epidemic. And they've done quite a lot. I mean, in a lot of, on average, HIV prevalence and incidence has gone down by more than 70% in a lot of countries. So that's why actually it's now off the radar, because it's now the new infections that are coming among young people that are bothering us.
And women.
Among young women, that are bothering us. But it's not the same as what used to be before. Yeah.
So you've written a lot about how patriarchal society is in Botswana. And I'm curious as to what your thoughts are, and I've been thinking a lot about this as well, bringing men along as allies. How do you actually nurture that allyship?
Men
Because we need to do it with men. Can't do it alone.
It's interesting. When we look at that, we think maybe it's the origin of how our society was ruled by chiefs and kings, and they were all men. Because in terms of getting women educated and all that, nobody even bothered. It's just, girls will go to school at the age of 5, whereas boys sometimes, because they have to take care of cows and all that, they go at the age of 9. So that in the ultimate, girls become more educated. So you find that in 48% of the high class, of the top positions, like the governor of the Bank of Botswana, it's women. It's only when it comes to politics that the patriarchy comes out. And it's interesting how even right now, if I try to run for presidency of Botswana, chances are that they're not going to vote for me, and it will be the women too who will not vote for me. They would rather take, even if they don't know you, Iran, it will be like, no, we'd rather vote for him. Because women, you can just never, so it's something that we've battled with, and I don't know whether we want to give up or what. Yeah,
but we better not give up. No, we
won't give up. But we need to really emphasize and ensure that we educate women. They are the ones who vote for women. But no, most of the time they vote for a man.
Do you believe in quotas? Like Rwanda, Kagame gave a quota for the percentage of women that had to be in parliament, and now they have 60%.
In fact, we have actually talked about quotas, and the problem is it has to be debated and voted for in the National Assembly. And guess who is there? Is the men. When I was minister, there were only 8 of us. In a parliament of 60, there were only 8 of us. And it was interesting that all of us were more educated than the men. And each time we're talking about having more women in, some of the men would say, when we have qualified women, we'll get it. And I used to say to them, what qualifications do you want? What qualification do you have? You get into parliament, some of you get into parliament and sleep. Why can't we have a few women come in here and also sleep? So it's basically that. So if the men themselves said, when we have qualified women, I was the only professor in there. The rest of them had bachelor's degrees, but they thought they were qualified. And so it's really interesting. And women believe that. So we need to really have that mindset change. Yeah.
I'm going to move a little bit to your personal life. This woman, well, you have an interest in acting from way back. She actually starred in the First Lady's Detective Agency, the movie. Do you want to tell us a little bit how acting helps you with negotiations?
Acting...
Or does it?
No, it helps. It helps all the time. I mean, when I told you about the president who was very, mad with me for mentioning men who have sex with men, that was acting proper. Because I was as low as possible. And inwardly I was thinking, stupid, let's talk about your people. These are your people. But hey, it was your excellency. So it helps. Acting does help quite a lot. And I've taught even nurses, to do the acting skills, because sometimes even dealing with patients, it requires those acting skills. So I've acted. I could have been in Hollywood by now if Anthony Minghella had not passed away. But I decided, okay, I'll stick to health. I'm okay. However, I still continue using these skills. And what I also did, though, I ran a traveling theater where during the summer, I would take nursing and other students to go out into the communities on a tour of acting. We'd put a play, let's say, promoting family planning, a play on HIV, and we'd take it out. And they were very well received. Yeah. So I made sure that I continued with my acting career, because my career of choice before I even became a nurse was to act. But I was simply told that we don't have a scholarship for that. So, okay.
Who are your role models?
Pardon?
Who are your role models in life?
Who are my role models?
Who were?
Well,
because you've obviously developed into this amazingly
strong...
strong...
I would say my parents. My mother is still alive. She's 96. My father passed away 2 years ago at the age of 94. So they were both same age. And my father was the best feminist ever. Even at home, he insisted that we girls don't do anything at home, because when we come from school, chances are we'll be asked to wash the dishes and do that, whereas the boys were not doing anything. So in the morning, the boys were the ones who cooked and did everything in the evening. So he was that kind of feminist, and he kept saying to me, each time I had done well, he would say to me, I wish you were a boy. And I say, I'm sure I disappointed you, Dad. But even on his deathbed, he was saying he wished I had been a boy. But the point is, when I asked him to explain himself, he said, you are doing so much. But I know because you are a girl, there will always be things placed before you. If you were a male, you could actually end up being president of this country. So when I joined the UN, he would say, you should have been a boy. And I said, Dad, what? And he said, by now you'd be Ban Ki-moon. You'd be in New York. Yeah, so it was basically that. But those two were really my role models.
Talk to me a little bit about aging in Africa. I was at a Rockefeller meeting in Bellagio where we talked about longevity.
Yes.
And what was very clear from LMIC countries is that they're having rapid urbanization, and the elderly folks are being left back in the villages and not being as aggressively cared for. Do you see this happening in Botswana at all, with urbanization?
Well, this happened in Botswana a long time ago. Before I was minister, I teamed with the University of Oslo to do research on aging, comparing the lived experiences of the elderly in Norway and in Botswana. And out of that, we actually then did a symposium. This is data. That's when I knew that data really helps research. So then I convened all the ministries that were responsible for, elder care. Let's say the Ministry of Social Justice, local government, the Ministry of Housing. And we had a workshop for them. And that's when our government instituted an old age pension, where if you've never worked in your life, once you turn 65, you had 300 pula. Now it's about 700 pula, which is actually more than the average salary. So you had that per month to assist with you. And that helped a lot, especially during the AIDS pandemic, when the elderly sometimes were left with the orphans. They actually used that old age pension. And sometimes that elderly person was the only person who was having, who had income, and they used that. So it helped, that helped. And as a result, we saw the rural areas being developed to the point where there is nothing like urbanization. If you go to Botswana, the rural areas are far more developed than in the urban areas. So as a result, you will not see a beggar in Botswana. You will not see a school going, some of these little children who are just not going to school. So it is that kind of thing that really helped then to ensure that rural areas are developed enough that people stay there. They don't come to the urban areas. Yeah.
I'm going to end with a last question. You're sitting in a room with researchers, and I heard very clearly the difference between research and policy advocacy, and that one needs to think about doing both. So what would be your words to the folks in the audience on how to best translate their research into advocacy?
Okay.
Or become an influencer, besides being on TikTok?
Well, I think the best thing, the first thing is to disseminate. And I know at academic level, we want, peer-reviewed international journals. That's nice. But advocacy would then mean taking that and condensing it and meeting, whether it's a congressman or whatever, to say, this is what I'm finding in our community. And not the big one, but as I said, 2-3 pages to say it has implications on what we are doing and have it like that. We had research, somebody presented research from India on the toilets. That's okay, peer-reviewed journals, fine, but condense it down. If there's a congressperson there, a member of parliament, a chief, or whatever, condense that into a few pages and convince them that if you had toilets that were paid for, where people are hired to be able to take care of these, this is what will happen. This is what we found can happen. And this is what it will cost you. Half the time people just present research and they they don't cost it. So if you do that, even when I was a minister, you gave me that, it was like, go and cost it. Tell me how much it is, it will cost. So it's basically that, yeah.
So why don't we open it up to questions from the audience?
Thank you so much for this wonderful presentation, just talk and everything. My question is really about prevention that you mentioned around preventing, say, sexual reproductive health conditions for women, and just how you think about setting incentive structures in place. So if, for instance, the government is putting a lot of money towards prevention programs, would you recommend that the beneficiary in this case doesn't pay anything at all and it's a free program for them? Or would you recommend prioritizing this in some way for beneficiaries where they actually start paying? And at what stage does it go from free to paid for beneficiaries?
I guess it depends a lot on the country. Having been a regional director for Eastern and Southern Africa, the advocacy was really for services to be free, because then nobody shies out. It came from the aspect of health being a right, and if it's a right, it should be accessible to everybody. And therefore, if people have to pay, and you find that in any event, people are already paying. If I'm going from here to the next, ward, and I have to pay transportation, right? So that you find somewhere there's those, out-of-pocket expenses that people have to go through anyway. So that with the advent of HIV, it was simply that to say you cannot have people pay for ARVs or for anything like that. Yeah, because that the tests. In some countries people had to pay for tests, but when I became regional director, it was to sit down with some of the ministers and to say, find out how you can subsidize the test, because if I can't pay for a test for my CD4 cell count, how am I going to then access medicines? without that knowledge. So it really meant, yeah. And that helped. We didn't have people shy away because when coupled with that was also multidisciplinary research looking at stigma. Because sometimes we think, okay, people won't come because of, but we had to bring down the stigma related to HIV and all that. Yeah. So a lot of these things are not like cut and paste. You are dealing with a multitude of things. And you want also a multidisciplinary impact where when people are doing this, they're also doing research on this. When we were rolling out the plan on mother-to-child transmission, we had to have to, at that time, remember, because there was very little evidence on information on HIV, we were doing KAP studies. So we had to involve mothers-in-law, because as a mother-in-law, she has to be the one taking care of a woman who is infected, and there has to be no stigma attached to the fact that this woman will later be given milk instead of breastfeeding. And breastfeeding in a country that is 90% breastfeeding, and you are not breastfeeding. So the stigma attached to that, we had to just simply ensure that before we even do anything, let's deal with grandparents, let's deal with mothers-in-law. And it helped a lot, yeah.
Thank you for the talk. You mentioned the problem of brain drain. I'm interested in what solutions do you think countries like Zimbabwe and Botswana can implement to sort of encourage their talent to stay in country, especially in the healthcare sector?
It's just to improve the conditions. That's it. And sometimes people say improve the salary. It's not a question of salaries. The pound is meant to be eaten in Britain, and the pula and to be eaten in Botswana. So you can't equate the two. However, we can do the basic, ensure that people have access to housing. There is career development. There is value, people are valued. And indeed, that, access to services such as schooling for their children. So sometimes at home, it's not even a question of salaries. It's just the basic that can be done so that people are comfortable in their home environment. I usually say people don't want to leave their countries to go outside. When they do, it's because they have pressing needs and they've tried everything else and it's not working. So it's upon our leaders, therefore, to retain the very people that they wasted so much money on, educating, and to ensure that they are given that leadership, that whatever, to be recognized at home. So that's all. But in terms of then having more health personnel, it's a question of collaboration. I'm taking your question, Zimbabwe and Botswana. If you look at our facilities, we have facilities to train thousands of nurses, but some of them are idle. Why? Because we don't have the required health personnel in terms of the lecturers. They're not there. So we need to collaborate, therefore, in having the few lecturers who are there to be able to train and then produce more. That's basically all we need to do. Yeah. And then collaborate internationally, where we have a school such as, Stanford has no nursing school, but Johns Hopkins, have faculty come over, teach during the summer, have a student exchange and all that. We can do a lot. It's just that nobody seems to be wanting to be the one to start. But I'm sure there are funders out there who can be able to say, let's start something, because we'll always have that shortage. The shortage now for nurses and midwives is 6 million, and it's projected to be 15 million by the 2025, when we are expecting more. So how do we get universal health coverage when we have that kind of shortage? I don't think so. Yeah.
I mean, it's right now about 20% of our nurses are foreign trained.
Yes.
And in the US. And what's been talked about with the US and UK is reparations, perhaps. Yeah. Every time you take a nurse from another country, that you give reparations. There's a great deal of discussion about that. I'm not holding my breath about it, but there is discussion.
We don't know. But then we also have nurses move between Canada and US.
Right.
Because in the ultimate, I usually say, look, in the ultimate, nursing right now seems to be the most expensive, up to date or whatever, is a commodity. And therefore, people, do have the right to move. But when they do move, they should therefore be, they should be under the same conditions as the people that you find in that country. We've had instances where nurses have moved only to be exploited, but then that shouldn't happen. Yeah.
Another question.
Thank you. Hi. Thank you for speaking with us today. My name's Zoe. I'm a first-year medical student here. And so my question was about, I know that you said that the solution isn't money with retention of healthcare workers, but what do you think the role is of reparations in perhaps like improving working conditions in the healthcare sector? And I'm also asking that because I've spoken, or I've heard most about the reparations argument from global north-based researchers actually, and I haven't yet had the opportunity to speak to Africans about like, is there a movement like on the continent for like reparations and acknowledging the benefits that they perhaps could do in so many sectors and development in general?
There's movement of health personnel outside of Africa, but also movement within Africa. When I was minister, because of what was happening in the country, I didn't lose a single nurse or doctor to any place, but I poached from other countries. So that, and for me, when we're talking about, the brain drain, other ministers will say, Sheila, don't forget you're also brain draining. And I say, but they're in Africa. They're not going outside. But the point is, 7% of my doctors and nurses were coming from other countries. And so it was basically that. And at that time, there were conflicts in countries. And yes, health personnel will run away from conflict. It's not safe. And there were also just the ordinary thing that they wanted greener pastures and just to show that, they didn't want to go outside. They went within a country that is in Africa. So even now, I still have Ghanaians, I have Nigerians, I have basically the whole of Africa, especially Francophone, DRC, even Burkina Faso is in Botswana. They came and they stayed to show that where they're able to grow and all that, they will stay. Yeah.
Can I ask you one question? I've asked you many, and I'm sorry to bring this one up. We talk about global health being equity, but so much of global health has been ensconced within colonialism and the legacy of white supremacy. How do you actually work towards forming collaborations that really are equal?
I believe that collaborations have to start first within Africa itself. We have the African Union, and it's interesting how, for example, right now we have a global agreement within Africa, the Africa that we want. But are our own presidents working on that? What's the situation in Africa? So that if we could have that collaboration, that equity, and ensuring that we share our resources, then it will be easier to get to the outside world without feeling that inferiority that I'm being helped by Americans, it should have been the Africans. So we need to start from within. Charity, as we say, should begin at home. And right now, and not a lot is happening. So it's one of those things that I keep pointing to our own presidents. We as ambassador of malaria, since they are the ones who called me, I didn't call them. I tell them that let's start with the basic, the manufacturing of bed nets. Can it start in Africa? Can we have access to the point where every villager in a malaria zone has access to that? So those are some of the things. We shouldn't then be waiting to have mosquito nets coming in from the Bill Gates Foundation when they can be done in Africa. So we have to start first there, and then we can collaborate with the world, and we can then talk about equity, based on that.
Thank you very much. I see Iran, the hook is coming out.
I'm the one who is going to both, unfortunately, end this conversation, but also invite everybody to a reception right outside. I want to thank everybody again, and especially I want to thank Michele and Sheila, and please welcome me.
Thank you very much.